Welcome to the post-dinner session. Hope everybody is well. This morning we will start with a session on nonlinear models, which is in a way a prelude to today's clinical trial day. And we have 3 talks on themes related to pharmaco whatever and to chemistry and related things. And the first talk of this morning will be by Katrin Roth from Schering Pharma. And it is about adaptive designs and so on for those escalation studies. Please, Katrin.
Okay, good morning. Can you hear me in the back? Okay. First of all, I want to thank the organizers for giving me the opportunity to speak here today. I'm going to speak about some of the things I've been working on for my PhD. And today it's about adaptive designs for dose escalation studies and the results of a simulation study. This is not working yet, it is. Okay. First of all, what are dose escalation? No. Here's the outline first. I was too fast with this. First, I want to give you a short introduction to the topic of dose escalation studies, and then present a traditional design for this type of studies, the 3+3 design. Then I'll introduce a parametric approach, what I call the modified 3+3 design, and then I'll present the results of the simulation study. What are dose escalation studies? They are medical studies conducted in humans, and they are among the first studies that are conducted in humans. So typically they are small scale, means very few patients are included, and we want to estimate, not test, and we want to learn about the dose-response relationship. The primary interest is in the safety of the drug, not the efficacy. And here we're dealing with the specific goal of finding the so-called maximum tolerated dose. That is the dose that we consider tolerable according to the toxicity that is induced by this dose. I give a more specific definition later. Okay, typically, if we are lucky, we have these dose response curves. The red one is for the toxicity and the black one for the efficacy. And hopefully the efficacy curve lies to the left of the toxicity curve, so we can define a therapeutic window. That's the space between the minimum effective dose and the maximum tolerated dose. With these types of studies, we encounter some problems and challenges. First of all, we don't have much experience with the drug in humans, so we have no idea how the human body will respond to the drug. So, and we have no or little prior knowledge about the model parameters, and everything that's related to it. And since we are doing tests on humans, we have to consider a lot of ethical concerns. We don't want to treat people at highly toxic doses, but we don't want to treat patients, that is, like sick people, at ineffective doses. And in general, we want to use as few people as necessary. But still, we want to get reliable results, and that's kind of a contradiction. And to deal with these problems, there are some specific methods. The first I want to introduce here is the 3+3 design. To conduct this design, we define a sequence of doses. Then we treat cohorts of 3 patients and start with the lowest dose. If we consider the dose to be safe, we will escalate. If we think it's too toxic, we de-escalate. And if we're not sure if the dose is toxic or not, we treat 3 more patients at the same dose. What is exactly safe and toxic, I will show in an example later. For this design, we need some assumptions. First of all, we assume that the maximum tolerated dose is the maximal dose with probability of toxicity less than 1/3. And the outcome is a binary toxicity outcome. We have to define the so-called dose-limiting toxicities. So we either observe a dose-limiting toxicity or we don't. The definition which toxicity is dose-limiting depends on the disease to be treated and a lot of other factors, and this definition is determined by not by a statistician but by medical people. We don't need a parametric model for this approach, which helps. And we just have to assume that the probability of toxicity is monotonously increasing with dose, but that is a reasonable assumption. Okay, in more detail, to conduct this design, we can use this chart. It's a bit technically. Basically, the next step only depends on the number of dose-limiting toxicities we observe at the current step, and then we escalate, we de-escalate, or we stay at the same dose. And we have a stopping criterion. At some point, we will stop. Okay, I'm going to show you an example because this might be a bit hard to understand before. This is an example from a real study conducted. Here we have the dose steps, dose levels that are not actual doses, just like symbolized by these numbers. And here we have the patients, all different patients that were included in the study, 3 at a time. We started at the lowest dose level, and this black triangle means that for this patient, we observed a dose-limiting toxicity. Here, 1 out of the 3 first patients had this dose-limiting toxicity, so we included 3 more patients at the same dose step. Then none of the second cohort experienced a dose-limiting toxicity, so we escalated the dose. And then a long time, nothing happened. All patients were well until we reached dose step 10. Again, in the first cohort, we had 1 dose-limiting toxicity, in the second, none. So we continued escalating. And then on dose step 12, 2 out of 3 patients experienced a dose-limiting toxicity. That was too much, so we de-escalated. And then had 6 patients on dose step 11. And there we stopped. And we concluded that dose step 11 is the maximum tolerated dose because it's the highest dose with estimated or observed toxicity rate less than 1/3. Okay. The properties of this 3+3 design, typically we only observe a small number of dose-limiting toxicities in these studies. It's like 3 or 4 DLTs in the whole study. But when the starting dose is very low compared to the actual MTD, we need to include lots of patients until we finally reach the MTD, so the number of patients gets large. In the example before, we had 45 patients, and that is a lot for a phase 1 study. Usually we try to have like 20 to maybe 30 patients, not more. The probability of finding the correct MTD is very low. Often it's 30% or less. So this algorithm or this design is not very precise in finding what we're trying to find. But the good thing is we don't tend to overestimate the MTD. We rather underestimate. So it's a conservative method, and it's safe for the patients. And additionally, it's easy to use in practice because the clinicians that conduct the study don't have to do complicated calculations during the study. They just follow this chart, and then they don't have to do interim calculations or anything. That's why it's quite popular. Okay. But we've seen that it's not perfect, so other models and designs have been proposed recently. A lot of Bayesian approaches, for example, the continual reassessment methods, There are parametric methods, non-parametric methods. There are designs and models for different outcomes, not only for binary, but also for categorical and continuous outcomes. And also not only univariate, but bivariate outcomes have been considered. I want to focus on comparing this 3+3 design with a Bayesian approach and an adaptive parametric approach. Okay. This parametric approach I'm going to present now. The general idea is that I select a model that is appropriate for the dose-response relationship. For example, a logistic model or a proportional odds model. Then I start using this 3+3 design until I have enough data to estimate the parameters in the selected model. With this data, I construct a locally optimal design conditioned on the previous observations and the estimated parameters. And then I treat the next cohort of patients according to this optimal design, and I continue until I reach some stopping criterion. And after each step, I adjust the design. Okay, so that would look like this. I start out with the 3+3 design. I check if the maximum likelihood estimator exists for the observed data and the model I selected. If yes, I can estimate the parameters and then determine this new design. Okay, what is this conditional locally optimal design? What I want to do is maximize the overall information of the experiments when I allocate n additional subjects to doses within a defined design region and treating the design points used so far as forced measurements. I want to include the information I got from the previous observations. I don't want to ignore them. Some notations. The design points used so far, called x-obs for observation. The estimated parameters for the model are theta hat. The information matrix for the design points x and the parameters theta, I call m of x and theta. And the design region is capital X. Then the conditional information matrix, MC, for the previous design points and the estimated parameters theta hat. The conditional information matrix is the observation matrix of the previous design points and the estimated parameters plus the information matrices of all new design points xi, where xi is in the design region. And then I just have to maximize some function of MC, whatever optimality criterion I choose. Okay. To conduct this, I have to specify some things. First of all, I need the sequence of doses. This can be the same as for the 3+3 design. I need a stopping rule, which here is the maximum sample size. I have to settle for an optimality criterion. I need the cohort size, and I need to define my design space, the design region. Okay. And when I set all this, I can conduct this study according to this adaptive design. Okay, to try how this works out, I did a simulation study, and I considered a lot of different dose-response scenarios. I'm not going to present the results on all of them here. I included some scenarios based on a logistic model and some on another model, on an Emacs model, because I wanted to know how this works when the real model and the model that I fit aren't the same. So I had two scenarios that were based to a model I fit to real data, where I have different parameters, different MTDs. Then I added a scenario that's safe and one that's pretty toxic, and then two more where I fit not a logistic but an Emacs model. Okay. I had to specify some parameters, as I said before. I used this range of doses from 0.6 to 29.4 milligrams that were doses used in a real study. I did 100,000 simulation runs on each scenario and each setting. And the underlying model that I chose was logistic. And both for the Bayesian approach that I used and for this parametric approach that I presented. Okay, as I mentioned before that I compared it to a Bayesian approach. That's an approach implemented in the software tool Bayesian Adapt. And I haven't really understood how this software works. There's very few documentation, but you need to specify some parameters there as well. And then you have to specify a priori information. And I put in like the least information that I could. That means I put in 2 points of a priori information that's like toxic dose 20, toxic dose 50. And then this a priori information is like worth 1 observation. So that's very little information and has not much effect on the conduct of the simulation. You have to specify what gain function to use. I consider 2 different gain functions. That is kind of an analogon to the optimality criterion. With the variance gain function, the next dose that is chosen for the design minimizes the variance of the estimators. And with the patient gain function, the gain for the next cohort of patients is optimized. I consider different cohort sizes, 1, 2, and 3. I'm only going to present results for 1 and 2 here. And then I took the default stopping criterion that is related to the width of the confidence or credibility interval of the estimators. For the parametric approach I presented before, I chose the D criterion and the C criterion because for the MTD, I took the MTD as a linear function of the parameters. I considered the cohort sizes 1 and 2. 1 turned out to be better, so I'm going to present the results for 1 here. As a lower border for the design space, I took 0 because obviously we can't take doses below 0. The upper bound is a bit more complicated. I considered 2 different upper bounds correlated to the maximum dose level used so far and to the current estimated MTD. But I never went beyond the pre-specified dose range. Okay, and then I set the maximum sample size for comparison to the median sample size that I got from the 3+3 design runs. Okay, the results. I'm going to start with scenario 1. They are all pretty similar, so I'm just going to give 1 or 2 examples. Here, the correct MTD was 22 milligrams. That's the row in the middle, and here I have the numbers, the percentage of runs in which I got the MTD right. Then I have here the overestimation, probability of overestimation, of slight underestimation and strong underestimation of the MTD. As we can see in the 3+3 design, which is our reference, I had like a third of the, in 1/3 of the runs I had the right MTD as the estimated MTD. And here with this Bayesian approach with the different settings, my what I call hit rate was much higher. And with this modified 3+3 design, I'm somewhere in between, depending on the setting I used. With the 3+3 design and this modified 3+3, I have the problem that in some cases it is not possible to estimate any MTD. This is missing values here. That means when on the first step I already encounter a couple of dose-limiting toxicities, I can't go on. So this happens sometimes. Okay, this is the one side. The next side, well, hello? Not working? Yeah, no, here. I I didn't only have a look at the chance of finding the right MTD, but also at some other things. First of all, the sample size. I set the sample size of the modified 3+3 design to be about the same as this one. And in the Bayesian approach, the sample size was a bit lower. Then I had a look at the average number of dose-limiting toxicities observed in each run. For the 3+3 design, it was around 3. And here we see a big problem with the Bayesian approach. It is much higher. So we have about 9 patients suffering from severe toxicities in the study. And that's not very desirable. And if we have a look at the number of patients that we treat above the maximum tolerated dose, it is highly increased for the Bayesian approach. And here in comparison with the 3+3 design, the numbers are larger as in the original version, but they are still in an acceptable range. Then I had a look at the MSE to see how precise my parameter estimates are. And the MSE was largest with the original 3+3 design and best with the Bayesian approach, but at this cost of putting like danger on the patients. Okay, this was one scenario. The second is pretty similar. I'm going to skip that. The third as well. The fourth is a bit more interesting. This was this toxic scenario where we reached the MTD very early at a low dose step 7. And here the chance of finding the right MTD with a 3+3 design was very low, only 12%. And we could increase it pretty much by the modification and even more by this Bayesian approach. But if we have a look at the Bayesian approach, in like 20 to 30%, we find an MTD that is above the correct value. And again, we put the patients at a higher risk. I have another scenario that I want to show. This shows how the 3+3 design can fail in some cases. Here we have the correct MTD would be 16 milligrams, and we only have about 3% chance in the scenario of finding the right MTD with the 3+3 design. And in about 80% of the cases, we end up 2 doses too low or even more. These rates of getting the right MTD aren't very high here either, but they have definitely improved. Okay, this safety issues are the same again in each scenario. But here we can show that the modification does not increase the number of patients that experience dose-limiting toxicities. The sample size is a bit lower, and the chance of finding the right MTD is higher than in the original 3+3 design. Okay. So, what are the conclusions? I found out that the algorithm implemented in the software Bayesian Adapt has a good hit rate of finding the right MTD, but it also includes a high risk for the patients. So this is not recommendable to use in practice when we don't have real prior information, as it was the case here. The 3+3 design is most conservative, and the risk for the patients is lowest. So it is safe to use, but we have a high chance of underestimating the true MTD. This parametric modification of the 3+3 design has better chance of finding the right MTD, and it has only slightly increased risk for the patients. So I think this is a promising alternative that we have to investigate more. That's what I want to do. I want to have a look at a different stopping criterion. I want to consider the length of the confidence interval for the MTD as a stopping criterion. And I want to fit a different model, a proportional odds model, that's what I'm working on right now. And perfect in time. Here are some references. And I want to thank you for your attention. And feel free to ask questions.
Floor is now open for comments, discussion. Please.
I have some comments.
Yep.
I've been simulating and designing phase 1 clinical trials for
Okay.
roughly 20 years.
Okay.
And several of your conclusions don't seem right. In particular, when you use Bayesian designs, for example, something as simple as the continual reassessment method, and you compare them to one or two of the most common versions of the 3+3, and there are many versions, what you find is that if you count the number of toxicities rather than the number of patients treated above or below some particular target, what you find is 3+3 algorithms are in fact less safe, but they have a higher probability of treating patients at excessively toxic doses. I don't know what Bayesian design in particular you used. You said you didn't understand the software.
Yeah,
We do understand our software because we write it ourselves.
Yeah, that's probably that's a good comment. I wanted to include another comparison, not only this modification. So I took the software that was available for me and that was used in another simulation study, and that's the problems I encountered with that one.
I wanted to know what sort of time or other gap you have between successive cohorts, of these small cohorts.
Actually, I can't tell you that. It's in this. It really depends on the setting, how many patients are available. That's first of all, and then you don't treat like all the 3 patients at exactly the same time. You treat them successively, and I don't know about the time between cohorts.
I mean, the reason I'm asking is some studies I've looked at where there might be a week or 2 weeks before you get another lot of people, and you really have to think about fitting a cohort effect then.
Yeah,
And that would make a
Might
difference
be.
with your
Yeah.
small cohort.
definitely.
A general question, don't you have to define what is meant by toxic? Surely that will vary from...
Yes, that's what I said before. That's not up to a statistician to define what is toxic. That's defined by a clinician that's recorded really well, and they're like this. There exists like this common terminology criteria for toxicity. That's for cancer patients, and this long list, everything that could go wrong and that could have like side effects. And the exact definition, what is toxic, depends on the treatment you're using, on the disease, and it's more like a medical problem, not a statistical.
Yeah, but shouldn't it determine the kind of design that's used? If toxic was less serious for one drug but more serious for another, then...
Yeah, that's why we use these dose-limiting toxicities. If we have a serious disease, we define toxicity different than we have like wanted to treat headaches. So that's the medical side of it.
My problem is a standard one in a way, because it's been mentioned many times before. You base your inference on the conditional information matrix, but how does that relate to the actual variance of your estimators? It seems to me that your inference should be unconditional, not conditional. This should turn up in the simulations. When you simulate, if you will do some more simulation for the confidence interval, it should appear that the variance is actually the real variance is greater than what you expected, because it takes into account the variance of the design as well.
That might be. I haven't gotten to that point yet. So
I'm not saying that your design can still be very good, but it's the premise that is not
Yeah.
justified.
Yeah, I will look into that, how the variance of the estimators behave when I look at the confidence intervals.
Okay. I think we should move to the next talk. Thank Katrin again.